Uh, Thanks, Vikram. Thank you, Raju sir, Ankit, and the team here, Shekhar sir, for inviting me over. So my case is, I think this is going to be an overdose of patellar instability now. Slightly different, but. So my patient, she's a 15-year-old female. She came to me with complaints of left-sided patellar instability. There was no specific traumatic event preceding her episode of instability. She had had 3 episodes of very well recollected patellar dislocations. And because of this, now there is limitation in her activities of daily living. Basically, she's a child, but she stopped playing, stopped going out, and is stuck to the house. So that is why the parents brought her, and that is how she was walking. So if you see the left side, she's actually walking with a decreased foot progression angle, and the valgus on her left side is, I hope, quite apparent here when she walks. So the right side, again, there is reduced foot progression angle, but there is no valgus. On the left side, there is valgus with a reduced foot progression angle. And on standing, that is how she looks. So what is known as the Q angle is basically increased on the left side. The right limb appears straighter, and there is no hyperextension when she is standing from the lateral side. So on examination of her knee, there was no effusion. There was some patellar facet tenderness laterally. Range of motion was full. The cruciates collaterals were all normal. There was subtle J sign, not very prominent, but she was extremely apprehensive, and her Baton score was 2 out of 9, not indicative of much of hyperlaxity problem. That's her hip internal rotation compared on both the sides, almost identical. Hip external rotation, again identical. So we need to look at torsional profile on clinical examination in all these patients who come with patellar instability. And that's, of course, we operated on her. I don't have a very good clinical exam video looking at her J sign. She did not have a prominent J sign, but apprehension was prominent. This was taken, of course, under anesthesia. Not the right thing to do. That's a radiograph. That's a AP standing radiograph. So she's 15 years, but if you see, surprisingly, the phases have apparently fused. Lateral view is extremely shitty. We can't make out anything out of it, but I didn't want to repeat an X-ray just to look at the perfect overlap of the posterior condyle. Sometimes it becomes very difficult. Repeated radiation exposure, especially in females, is what I avoid. I did take AP radiograph of the right hand to make sure that her skeletal age is fit, because now my line of thinking was going in a particular direction. That's her AP standing scanogram. So if you see on the left side, the Mikulicz line passes lateral to the lateral tibial spine. So there is obvious lateral, there is valgus deformity on the left side. That's her LDFA, that's her MPTA calculation, and we calculated these. We found that the hip knee axis was 186, so there's almost about 6 degrees of valgus. However, surprisingly, and this is the first time that I encountered this, that her MPTA was elevated. It was 93.4. That meant that the entire valgus was arising from the tibia and not from the femur. This was extremely surprising. So till before the scanogram, I was thinking of, yes, valgus with patellar instability. So that means there is a problem in the femur, and that is why she's maltracking. But this was a complete surprise. Of course, an MRI, she had come to me with an MRI. We see this attenuation of the medial patellofemoral ligament. The trochlear dysplasia was not too much, and that's the mid-sagittal section showing a really long patellar tendon indicative of patella alta. And again, cruciates, corners were all normal. So we come to our first ARS question. If you can please put it up. All right. So when, in case of patellar instabilities, would you consider a CT scan? What are we looking at when we order a CT scan besides all these radiographs and a scanogram and an MRI? Okay, so always do both for TTTG and rotational profile. So yes, for rotational profile, yes, I would agree, but just to, if on clinical examination you don't suspect any rotational abnormalities, there is not much really that we gain by doing CT just to look at rotational profile for 2 reasons. Number one, rotational abnormalities can be picked up very much clinically, and when we have some amount of clinical suspicion, patient walking with a in-toeing gait, or on examination you find that there is difference in hip rotations, then yes, it makes sense. Second is, unless the person who's doing these interpretations is completely well versed with how to do a post protocol CT scan, will end up giving you very, horrible results. So that will confuse you rather. As regards TT-TG, so...
Anshu, your MRI had a bucket handle meniscus tear also.
No.
It did?
No, there was a...
Go back, your sagittal section, look at that.
This one? No, that's not a... That's a lateral side.
Lateral view, you can't see the posterior horn.
There it is.
And looks abnormal.
Don't confuse people more. Yeah, but there was no meniscus tear, yeah. We had scoped there, of course. Because I've started looking at discoid, fetish maybe. All right, so these are her patella indices. She had a type A trochlear dysplasia, and a trochlear dysplasia is present in more than 80-85% of patellar instability cases. Her Caton-Deschaux ratio was 1.4, which is significantly increased. Her TT-TG is 21 on the MRI. Remember, for an MRI, the cutoff values have to be lower. The trochlear inclination angle was 10 degrees. Femoral anteversion, this is again calculation given to me by the radiologist. I did not make these calculations. So femoral anteversion 21 degrees, which is pretty much normal. Tibial torsion of 26 degrees external, which is again, within the realm of normality. So this is what we end up with. 15-year-old child coming to us with patellar instability with a valgus knee, and those are her patellar indices. So that's a low-grade trochlear dysplasia, significant patella alta, and a medialized TT-TG. Of course, some literature support for why we cannot, and rather should not depend on a CT scan for TT-TG, because an MRI is good enough. The only thing to remember is TT-TG values for an MRI are at least 3 to 4 millimeters lower than what we see on a CT scan. So the 20 mm value holds good for a CT, but not for an MRI. For an MRI, maybe even 13, 14 millimeters would be the cutoff. So considering that, our patient has a 21 millimeters of TT-TG, which is increased by almost 6 millimeters, right? So the diagnosis that we had was skeletally mature patient with recurrent patellar instability, symptomatic, valgus knee lying with the deformity lying in the tibia, low-grade trochlear dysplasia, de jure type A, significant patella alta, increased TT-TG, attenuated MPFL, and a normal torsional profile. So this is the patient that we are dealing with now. So that comes to the second ARS question. If you could please put it up regarding what would be your plan for treating her now. Okay, so 11% people believe we should do a DFO when the deformity lies in the tibia. Okay, so trochleoplasty, okay, not many takers for trochleoplasty, great. So HTO, TTO, MPFLR. So that is what the majority of the house goes with. From the menu, we would want to, rather this is outside the menu, correct the coronal alignment. From the menu, of course, bring down the patella. Medializing the tibial tuberosity, of course, now when we are correcting valgus deformity, that itself will lead to some amount of correction of the TT-TG. So medialization, how much to do, this was a little, something that I decided I'll play around with after having done the osteotomy. And then, of course, doing a dynamic check-rein procedure by an MPFL reconstruction. So surgical plan was exposure by anterior midline exposure. Do a tibial tubercle osteotomy with a big biological plate, kind of a 6 millimeter long tongue. Planning showed that I needed to do a medial closing wedge osteotomy of about 5 millimeters. TT distalization of about 7 millimeters. Medialization, I decided to, not get fixated to a value, and I would decide after opening up, after closing the osteotomy. And I decided to do a quad tendon MPFL for the simple reason that it was a very small patella. I did not want any implants, no tunnels, of course, I never do tunnels, but even suture anchors, I did not want to do that. So just a quad technique which Deepak Goyal sir has described. Now, the confusing part for me was, how do we deal with, confounding factors of a high tibial osteotomy affecting the patellofemoral mechanics? Now, we do know there's, mountains of literature that in medial open wedge high tibial osteotomies, once you valgize them, the TT-TG changes, right? This is, of course, when the biplanar cut is going proximally. With a distal biplanar cut, changes on the patellofemoral mechanics are lesser. Uh, Also, we do know that medial opening wedge osteotomies will cause patella baha. So by the same logic, if I am to do a closing osteotomy, I would actually also cause some amount of patella alta. Now my patient already has patella alta, right? So I did not have guidelines. I could only infer from what was published in literature based on medial open wedge high tibial osteotomies for varus knees. And the surgical consideration that I absolutely had not thought of till the night before was, what do I do with the MCL? So we all talk of vigorous MCL release in medial open wedge HTOs. But here, where there is a valgus deformity, we are doing an osteotomy on the medial side, which is the convexity of the deformity. Now, I don't know how much to respect the distal insertion of the superficial MCL, but that is potentially a structure which is not pathological in this case at all, unlike in a varus knee. So what do we do with that? So anyways, I went ahead. Now this surgical video is from another patient, a similar osteotomy that I did more recently. So that I did a similar kind of a technique for her. Of course, that was an anterior midline exposure. So that's the flap, that is the gracilis graft in her case, which I had harvested for the MPFL. Remember, this is not the patient we are discussing. This is another patient. And that is the superficial MCL. So the superficial MCL, which inserts about, so that's again layer 2. The gracilis lying in layer 2, that's the superficial MCL. Now, I went and created a window at the back. So this would allow me to clear the muscle off and make sure that I put in my retractors comfortably without having to do too much of an MCL release. So that's the corpse that's going at the back. And this, of course, after I had fired the pins and done the osteotomy. So if you see, the MCL here is still attached. I'm protecting with the Langenbachs here. So this is what I did for this patient also. I did not touch the MCL insertion distally. I just tried to lift off from the bone as much as was required. Now this patient, of course, I did a proximal ascending biplanar cut, and that was the closing wedge. This is different from what I did in the patient we are discussing today. So in her, I had done a complete TTO with her anterior midline exposure. But the osteotomy was, of course, like this. It was wider posteriorly, narrower anteriorly. Of course, in this case, this was not complete. I had to remove this bone little at the back over here, and I had to chop off little bit of the bone over here, and only then did this osteotomy close. Right, so I did not shoot the video because I was too jittery during the surgery to wait for somebody to shoot a video. So that is basically what was done. Those are the pins for the osteotomy. That is how the osteotomy goes up to the hinge point. And this is what I got at the end of the day. So I ended up performing a distal femoral, medial tibial closing wedge osteotomy. That's the osteotomy. My tibial tuberosity, I distalized it. I had to medialize it by just a couple of millimeters. I don't know if I could make out a couple of millimeters. I was sure not to lateralize it at least. The patella was brought down by the TTO distalization. And then, of course, I had added MPFL reconstruction using a cord tendon, which was fixed at the shortest point using a peak screw. And that's her clinically once she had started full weight bearing. The assessment of her MPTA now reads 88.5, which is again within the realm of normality, which is 87 to 90 if we are to get there. And the CD ratio here was now reduced to 1. So we have brought down all our indices to where we wanted them to be. That is the patient, that's her complete knee range of motion. This is almost at the end of 8 months. She had a lot of difficulty getting back her flexion. But at the end of 8 months, there is complete knee flexion that we see there. That's her, I hope this place. Okay, so that is her, there's no extension lag. She is able to extend completely. She can do complete single leg stance, and she can also now do good squats without any problems.